And we'll wait a couple more minutes and we'll get started. I see participants are joining. Good afternoon to all of you here in Addis, and good morning to my colleagues in the US. Thank you very much for joining the webinar today. My name is Tigistu Adamu. I am the Chief Medical Officer at JPIGA, an international organization and affiliate of the Johns Hopkins University. As you all know, the rapid increase in the COVID-19 patients resulted in a huge and continuous and prolonged inflow of critical ill patients with a very high incidence of ARDS. And in all of our treatment centers, we are challenged to provide all patients with the best possible quality of care by allocating available resources. We have a situation now where we have scarcity or even the lack of equipment and supplies, such as ventilators, medications, and personal protective equipment. On top of that, we are operating with limited number of appropriately trained healthcare professionals. Even though we've had enough lead time to prepare for such a scenario, our preparation is proving kind of inadequate. The increasing and continuous inflow of patients combined with the high lengths of ICU stay is resulting in an overwhelmed treatment capacity. When critical care system reach saturation, like where we are now, our strategy must be adjusted to fairly allocate scarce resources in order to maximize the benefit to the greatest number of patients. And such prioritization is both individually and collectively ethical, provided it prevents arbitrary decisions and relies on objective elements that are shared between all of us healthcare professionals, decision makers, and the whole community. But this is easier said than done. So in today's webinar, we'll be discussing experience and evidence around prioritization of ICU admissions. And we'll also discuss scenarios from our hospitals and have some of our excellent clinicians weigh in and provide their experience and recommendations moving forward. Without further ado, I now invite the panelists in today's session to introduce themselves and their background and where they work. And throughout the session, for all of you participants, please use the chat room or the Q&A functions to ask questions and share your experience, and we'll be following that. With that, I will ask Adam to start introduction and all the panelists to follow. Adam?
Nice to Lynn. Good morning, everybody. My name is Adam Layton. I'm an emergency physician and intensive care physician at Johns Hopkins University Hospital in Baltimore, Maryland, in the US.
Tigistu?
Hello, everyone. I'm Tigistu and I'm an emergency and critical care physician from Addis Ababa. I'm currently working at the Addis Ababa COVID-19 Field Hospital.
Hello, everyone. My name is Radit Shmelis. I'm an anesthesiologist and critical care physician. I work at Gandhi Memorial Hospital here in Addis, in Ethiopia. I'm working with JPIGA and Mr. Pils regarding critical care capacity building projects. Thank you.
Membeo, do you want to continue?
Good afternoon, everyone from Addis. I'm Dr. Membeo. I'm emergency physician and intensivist working at St. Paul's Hospital Millennium Medical College, and I'm a critical care director in the college and also chairing Ethiopian Society of Emergency and Critical Care Professional. Thank you for having me all.
Thank you, Membeo. Bhakti?
Good morning, I'm Bhakti Hansodi. I'm an associate professor in the Department of Emergency Medicine at Johns Hopkins and the associate director for the Hopkins Center for Global Health. I've been the technical lead on the RISE activities supporting Ethiopia.
Thank you, Bhakti. Salam, do you mind trying one more time? Okay, Salam may have some challenges with the connection. So maybe we will just proceed with the first presentation we have. I'll invite Dr. Adam to share his presentation and start.
Thank you, Dr. Tigi. Can you guys see my slides okay?
Yes, we can.
Wonderful. So as you said, this is a very challenging topic. Unfortunately, there's no universal right answer, but I think having an organized approach to resource allocation can help to facilitate that process and make it work as well as possible. I want to start off with just a little bit of terminology. This gets very confusing in how people use this terminology and how people use it in the medical literature. We think of triage as a systematic method of sorting patients by the severity of their illness to match them with resources. And that's a little bit different than the issue of limited resource allocation or scarce resource allocation, which is a way of identifying which patients will receive access to healthcare resources when the need surpasses the supply. Severity scoring is a way of risk stratifying and prognosticating patients, and that's used for both triage and resource allocation, but not necessarily in the same way. So when we think about triage, we're looking at a group of patients and trying to sort them into which patients are unlikely to survive no matter what we do for them medically, which patients are at the highest need that should receive attention immediately, which patients need medical attention, but are able to wait or to go to a lower intensity of care, and which patients are do not need emergency or immediate medical attention. And severity scores is one way of sorting those patients. And then we think about limited resource allocation. This is a similar process, but we're thinking about which patients are going to get those limited resources. And in this case, we're thinking about ICU beds and mechanical ventilation, which patients are not sick enough to need those beds, and which patients will not receive those resources, maybe because they're too sick, or maybe because we just don't have enough resources for all of the eligible patients. So a couple of key principles that I think are important to keep in mind. Triage is not the same as limited resource allocation. It is important to have an objective, predetermined set of criteria that are applied consistently and transparently. Ideally, it's very helpful to have an ethical allocation committee that is not directly involved in the patient care that's making those ethical allocation decisions. And there's a real risk of moral distress, moral injury, and burnout for the providers who are making those resource allocations if we're not cognizant about doing this in an organized way. So when we think about illness severity scores that are being used for COVID-19, we have a number of scores, including the CRB65, the NEWS, the BCRSS score. These use factors like mental status, blood pressure, respiratory rate, body temperature, work of breathing, chest x-ray findings, oxygen saturation. These are all easily measurable physiologic, or mostly physiologic criteria that are easy to recognize at triage in the emergency department and help to figure out what level of care would be ideal to triage those patients to. But it's very important to keep in mind that while these are accurate in predicting the need for invasive respiratory support, they're not accurate in predicting mortality. And I think you've all probably seen this, that the level of a patient's illness changes over the course of their hospital stay. And so a patient who is afebrile with a normal heart rate and a normal respiratory rate on day 1 may be febrile, tachycardic, and tachypnic on day 5, and on day 10 or day 15, maybe back to having a more normal set of vital signs. And so it can be very problematic to use those sorts of scores to prognosticate. And there have been numerous studies showing that those physiologic scores are not helpful in predicting who is going to survive their COVID-19 infection. So when we think about, so I think in terms of thinking about how we perform triage, those can be helpful. That's a whole other talk that we can have another time, if that's not something that you guys have a good system in place for already. But when we talk about allocating limited resources, this is the situation where you have 2 available ventilators and 10 patients who need a ventilator. There's some different ethical principles that people use to decide who should get those resources. One is to say first come, first serve. So you go through the waiting room, and as you take in patients, if the resource is available for those patients, great. And if not, then they got there too late. That's certainly an option. That's usually not how we function, even in the emergency department on a normal non-pandemic, non-disaster day. We're still triaging patients to figure out who need attention the soonest. Doing first come, first serve also runs the risk that if that's a message that you're sending to the community, then people are going to think we need to come to the hospital immediately so that we get in line. And so that when we get sick enough that we may need to have a ventilator, we are already in that line waiting for a ventilator. So there's some challenges with first come, first serve as a strategy. Another option is to say who has the greatest need. We only give resources to the sickest patients. And so whichever patient is the most dire is the patient who gets those resources. And that's another option that people use. One challenge with that is that you may end up using a lot of resources on patients who are so sick that they're not going to survive no matter what you do, and not be able to use resources on patients who are likely to survive with timely interventions. Another option is the concept of utility, of trying to save the greatest number of lives. I think this is really what we all strive for ideally, but this is a challenge because we often don't know which patients will survive with appropriate interventions and which will not. It's a very challenging question to determine how do we use our resources in the most efficient way. Data is still evolving on this as we learn more and more about COVID-19 and as our therapeutic options improve. So I'll talk about this a bit more. A lot of times utility is driven by the concept of who's the most likely to survive. And often this is a concept that, if you're able to use 10% of resources on 10 patients and each of those patients is able to survive when they wouldn't have otherwise, most people would think that that's a more useful way of using that amount of resources than to spend all of those resources on one patient and have 9 other patients not survive. So we'll talk about this a bit more. And then another important concept is who's likeliest to have the long-term survival. So you may have heard that in Europe, often age was an important factor. There were stories that in Italy back in March, they were saying that anybody over the age of 75 or anybody over the age of 65 was not going to be intubated because they needed to conserve those resources for younger patients who were more likely to survive. This is also problematic. We don't have a great way of predicting long-term survival. We know that some people who are 60 years old will live for another 30 years. And some people who are 30 years old may only live for another 5 years. And so sometimes other medical conditions, comorbidities come into play with this. But this is certainly a criterion that has been discussed quite a bit. Stage of life goes with that to say that somebody who is young and raising a family, whether that's a 20-year-old who's raising a family or a 40-year-old who's raising a family, is in a different stage of their life than somebody whose children are all out of the house and that person is retired. Whatever that person's age is, maybe it makes sense to devote the resources to people who are at an earlier stage in their life, so that everybody gets a similar amount of life, even if that's not quantified in years. Special considerations are also discussed quite a bit. People have talked about whether we should give priority to healthcare workers who may have gotten infected because they were in the line of duty and made took a personal risk and a personal sacrifice that resulted in them getting infected. People, there's another utility argument that goes with prioritizing healthcare workers, because if one healthcare worker recovers and is able to go back to work and take care of more patients, they may be able to save more lives. Where if all of our healthcare workers are infected and not able to continue working, then our healthcare system collapses. People often talk about pregnant women as another special case, where if you save the life of a pregnant woman, really you're saving the life of the child as well, hopefully. And so some people have talked about giving special consideration for pregnant women. And then another concept that comes up is equal access. Everybody should get a fighting chance. We can do this as a lottery without any sort of ranking or prioritization. So I've listed a number of different concepts here, and I really want to stress that there's no single right or wrong choice. Really what's important is that you have a system that is consistent and transparent, so that when you tell a patient, yes, you are going to get access to this resource, or no, you are not, it's not saying, I'm Dr. Layton and this is the decision that I made. It's saying that this is the decision that we've made together as a medical society, ideally with input from the community as well as from the medical providers, to say that this is what we think is a fair way of allocating resources. And we're following a plan that we've agreed on. So there is some guidance from the National Comprehensive COVID-19 Clinical Management Handbook from the Ministry of Health. And so I'll read this very quickly. So in the case of limited supplies of life-saving interventions like mechanical ventilators, the decision of healthcare providers should be guided by the principles of first come, first serve and chances of survival based on the severity and reversibility of organ damage. And decision to discontinue life support in terminal cases depends on the existing practice in the country, such as confirmed brain death. So these are a couple of different short-term prediction scores. I'm not going to dwell on these too much. If you want the literature to go with this, most of this is open access and easily accessible online. But I just wanted you to see a few of the different scores that are out there that people are using to predict short-term, and usually this is 30-day mortality for critically ill patients with COVID. So this was a study out of China that looked at age, history of coronary artery disease, the lymphocyte count, procalcitonin, and D-dimer. Those are 3 lab markers. This was another Chinese study that was using the INR platelet count, then the QSOFA score, that's a physiologic score, as well as age and gender to assign scores. This was a score out of New York from this past year that used age, oxygen saturation, blood pressure, as well as markers of renal function, inflammation, and coagulopathy. This was one out of Italy that looked at age, comorbidities, and I'll talk a little bit more about how they scored comorbidities in just a minute. Respiratory rate, the P to F ratio, a measure of oxygenation, and then renal function and platelet count. And this score out of Britain that looked at age, sex, comorbidities, respiratory rate, oxygen saturation, GCS, renal function, inflammation. So a number of different prediction tools out there. None of these are very well tested or well validated. Most of these were developed in one center, and I don't know of a good meta-analysis or systematic review that's comparing numerous different scores of these novel COVID score mortality prediction scores. So I think that the choice of the score is most likely going to be driven by a local consensus and what scores are going to be easy to calculate in your setting. So if a procalcitonin is not something that you have easy access to, then that score probably is not the right one to go with. In my hospital, we don't use procalcitonin, so that would not be an option for me. Whereas the 4C score that just uses urea and CRP, I'd be able to get back in a shorter amount of time. So that might be a better choice in my setting. From the CDC, and the WHO has a very similar set of guidelines. There are a number of chronic medical conditions that we know are poor prognostic indicators specific for COVID-19. These include cancer, chronic kidney disease, COPD or emphysema, Down syndrome, coronary artery disease, congestive heart failure, history of organ transplant, obesity, pregnancy, sickle cell disease, smoking, and diabetes. So these are all patients who may be less likely to survive. And then when we look at long-term mortality prediction, there's no single good long-term mortality predictor specific to COVID-19. So this is the Charleston Comorbidity Index, which is used frequently to try to estimate whether somebody is 50 years old or somebody is 80 years old, what are the chances that this person is still going to be alive in 10 years from now? And so this is a calculator that you can find online easily also. That's a good way of figuring out what are the chances that this person is going to survive long term. I would just point out that this gives a lot of points to AIDS. This score was developed in the 80s when the prognosis for AIDS patients was very poor. And so that's something that you might want to take into consideration. Lastly, there are a few things that we should think about as providers and what our obligation to the community is. Distributive justice is the idea that we're going to come up with a fair system and we're going to stick to an organized system for how we allocate resources. We do have a duty to use resources in an ethical way and to conserve those resources for the patients who are most likely to benefit. We have a duty to have a plan. And even for patients who we're not able to provide life-saving therapy for, like a mechanical ventilator, we still have a duty to provide care for those patients. And whether that's treating their pain or their anxiety, or even just holding their hand and comforting those patients, the fact that we're not able to save a patient's life is not a reason to say that we should abandon that patient's care altogether, because we still have an ethical obligation to comfort our patients in their times of need. And then finally, I think it's very important that we're transparent and we're clear about what our resource allocation process is. And finally, we have a right to reciprocity, which means that because we're taking on all of these obligations and we're all making these making these hard decisions and sacrifices for our community, we have a right to be treated with respect. We have a right to be treated fairly, to have access to protective equipment, and to be acknowledged for the sacrifices and the hard work that we're making. Moral distress is a very real problem. This is the situation of knowing that there's a right thing that you want to do, but not being able to do it. Moral injury often is an impact of that moral distress, which is psychosocial, behavioral, and spiritual impacts of failing to prevent or witnessing acts that you think are immoral, or that you're not able to live up to the standard that you hold for yourself. And burnout is a very real consequence of that moral distress and moral injury. That can be emotional exhaustion, depersonalization, and a low sense of personal accomplishment. And working in such a challenging environment puts us all at a very, very real risk of burnout. I want to close by mentioning this is Dr. Lauren Abreen. She was an emergency physician in New York City in the trenches, really, during the epidemic in the beginning part of 2020, who experienced such severe moral distress, moral injury, and burnout that she went on to commit suicide and really tragically lost her life to severe burnout and moral injury, feeling like she just was not able to fulfill her professional obligation to save the lives of the patients coming to her for help. So I want to really close by saying that what you guys all do is heroic and patriotic, and you're serving your communities, and you deserve praise and recognition for that. But also, all of you are human beings, and suffering along with your patients is the most human thing that you do at work. And we need to take that seriously and acknowledge that. We know that even before COVID-19, the suicide rate among physicians was twice that of the general population in the US. And a lot of that has to do with the whole high standards that we hold ourselves to and the high risk of moral injury and burnout. I think an important first step is really for us to acknowledge that this is going on, feel comfortable talking with our colleagues and understanding that we're all suffering from this together. And then thinking about ways that the institutions are able to support physicians more in coping with the severe stresses of taking care of patients during the pandemic. So thank you all for the work that you do. And I will stop sharing my screen and move on to the next speaker.
Great, thank you very much, Dr. Adam. That's really and important points that Adam raised in terms of, the broader framework and how, we really need to look at the different components and be very context specific, and also really emphasizing the point that this is not an easy feat to do. So we'll move on to our next session, which is pretty much how is this kind of framework translated? What are the scenarios in our hospital? So Dr. Tigistu will lead us with like a couple of slides to just share scenarios that will help us in a panel discussion. Dr. Tigistu, over to you.
Okay, thank you very much. So I'm going to briefly highlight on the things that we are facing at the Addis Ababa COVID-19 field hospital. For those of you that don't know the Addis Ababa COVID field hospital, it was established on September 11. And we used to accept patients starting from mild, moderate, severe, as well as ICU. So the ward capacity, we have initially there is a triage. We have 2 beds. The emergency room comprises of 10 beds. We have 3 different wards, ward A, B, C. Each of them have 28 beds, and then the ICU 10 beds. So since the start of our hospital, we have given service for more than 1,000 patients during these 7 months. And currently, we also have around 86 patients in the wards. So I'm going to share some statistics regarding what's happening in our hospital this past few months, specifically from Third to Magabit. So as you can see, initially, when we started admitting patients, most of the patients were mild to moderate patients. But starting from Yakatit, as you can see, there was a significant doubling of patients. Initially, it was 139 in the month of Ter, and now in Yakatit, we are having literally double the cases, that's 233. And most of the patients that come are admitted in the severe ward or ICU. So we have shifted completely and we no longer admit mild cases in our hospital. We just admit moderate, severe, and ICUs. And as you can see, even the death rate also has increased tremendously from the previous months, as shown in the figure projected. Even in the current months that we are in, we have seen around 76 patients total admission within as you know, it's almost 2 weeks. And then we have seen 76 patients, out of which 24 of them are in the severe wards. And then we have 5 new admissions. So currently we have a total of 10 admissions in the ICU. So I'm going to proceed with our challenge. So the challenge we face, since our staff are doing rotation every 2 months, there is a continuous need for the training for the staffs. To avoid the staff burnouts, we rotate them every 2 months. So the staff, we get each new staffs every 2 months. And also our topic of discussion today, the admission criteria for the ICU. On a daily basis, we have waiting lists from our wards, from the severe wards. Even currently, as we are speaking, we have 12 patients waiting to be transferred from the severe ward to the ICUs. We have 20 patients waiting for the admission to the severe wards. So this shows you the need for the ICU and the severe wards. So if we have the admission criteria for the ICU, if we have different, I think Dr. Salam is gonna talk in detail about the challenge that we personally face. We have different case scenarios, different patients, each requiring the ICU beds, but since we don't have the clear-cut diagnosis, clear-cut admission criteria, we are faced with difficulty in admitting them. The other challenge we face in the field hospital are lack of non-rebreather masks. And since we also admit different age groups, we also face different size face masks, CPAP machines, mechanical ventilators. And currently we're also facing challenge in oxygen as well, and also ventilators. And also, we also have lack of laboratory tests like chemistry, electrolytes, ABGs, and coagulation profile. And even though we have ultrasound in our setup, we don't have the portable X-ray, so we have lack of imaging as well. Staff burnout, well, since we are rotating the staffs, at least majority of the staffs will rotate every 2 months, but the consultants are usually fixed, so we don't have the luxury of transferring them every 2 months. So there's a chance of staff burnout as well. So this is the highlight on our criteria, our challenge that we are facing in the field hospital.
Great. Thank you very much, Dr. Tigist. I think, what you shared about, what you're doing and currently what's happening at the field hospital, and what Adam talked about, like what kind of framework and what kind of protocol or criteria should we put in place, are really like closely together, because this is really like a challenge of, practical matter. So maybe to then help us dig a little bit deeper and have, continue on the conversation, I'll invite, so the three panelists, Drs. Salam, Renit, and Mambo, to look at it from a broader perspective, as well as being very specific, especially like from your current practice in terms of the challenges, from a broader perspective, because this is not a new problem we have in our critical care system in the country. But things have changed with the pandemic. And as Adam mentioned in his presentation, it is really creating a huge toll on the community as well as the healthcare workers. So maybe if I can start with Dr. Salam, because you're also working at the field hospital. What are the things that you're seeing as challenging for you as a practicing clinician working in this situation to make this kind of tough decisions on a day-to-day basis? Dr. Salam?
Okay. The problem we're facing mainly is, obviously, we have limited resources. And in order to allocate those resources, the problem is the government hasn't, the limited resource allocation principle hasn't been regionally activated by the regional authorities, and it's not publicly announced, and it hasn't even been evaluated for the public. So in addition to the moral dilemmas and the burnout risk, we're also in fear of risking our licenses, because if I prioritize a patient based on his long-term survival or the short-term outcomes, I would still be liable in front of the law, because if a patient decides to press charges because his father or mother or a family member was not prioritized, still I'm not legally protected. So if these principles, the ethical principles in times of pandemic, are not activated by the regional authorities, our hands are tied. We can't prioritize patients, but still, because we're losing so many patients, we sometimes overlook that and we try to prioritize patients. But the problem with that is, as I said, it's very morally exhausting, and at the same time, it's scary for us because we can't practice it freely.
Great, thank you, Dr. Salam. Maybe I'll come back to have some follow-up question on some of the things that you mentioned. But then in the meantime, Dr. Mambo, you've been working in the critical care environment for quite some time and leading the professional association and working with the Ministry of Health. So what are your observations on a day-to-day basis in terms of the challenges, as well as implementing some of the elements of the framework for an objective criteria to admit patients to ICU and really avoid the challenges that Salam has mentioned and Tigist mentioned earlier? Dr. Mambo?
Thank you, Tigistu, and thank you, everyone. So this is a very important issue. Even before COVID era, we were facing the challenges of allocating the limited ICU resource previously. If I can mention St. Paul's Hospital, we had 14 beds in our ICU, but St. Paul's need up to 60 ICU beds previously, prior to COVID. So for those 14 beds, we have to allocate for like 60 patients needs our bed, but we are having 14 beds only. So we have to prioritize patients to admit to ICU. So for this, we were using the Ministry of Health admission guideline. It has a kind of priority model, like priority model 1, 2, 3, 4, and 4A and B. It is adopted from, I think, International Society of Intensive Care Medicine. So with that, we were trying to allocate our limited resource to those who can benefit better, or those patients who benefit the most. But most of our ICUs are kind of open, and anyone can admit from any wards or from emergency. It was so difficult to allocate or to use that priority model in all our ICUs. COVID came and the things get worsened because we have to share our ICU to COVID. Those 14-bed ICU went to COVID, and we are left with 6 beds, extra beds for non-COVID patients. So you can imagine the shortage of ICU beds in non-COVID area also. So as much patients we are losing in COVID area, in COVID disease, we are losing patients in non-COVID ICUs, because our national bed in COVID in non-COVID ICU is less than almost 250. So allocating and the prioritization of patients whom to admit ICU is very important in Ethiopia, but it is so challenging whom to admit to ICU. But we were using the ICU prioritization model. Still we are using it, but it has a difficulty. When we come to COVID, when we are having 14-bed COVID ICU in our hospital, that most of the patients are being referred from a National Emergency Operating Center. So they are prioritizing patients to admit. So we are still having a difficulty to prioritize. That is why we are getting to our ICUs the most critical and those patients who are less benefiting from ICU care. Because as we are hearing recently, almost what we are providing in critical care area is half of the demand. There are around 600 patients requesting for ICU, but providing less than half. So there is waiting list for patients in COVID ICU. So we have to have a priority model whom will benefit most in our ICU. Now we are not that much deciding which patients we are admitting to ICU. So the other option we are having after admitting the patients to ICU, we plan to have a kind of categorizing patients. Which patient will benefit most from our increment of medication and invasive management? Like category 1 patients are kind of patients who will benefit most from all our efforts, and the category 4 patients will be a patient probably brain-based patients, like, or category 3 will be a kind of patient we have malignancy or multi-organ failure for COVID, including shock, respiratory failure, and renal failure, or we are not escalating management like dialysis. So we are having that kind of model, but like my previous colleagues mentioned, using it in day-to-day practice, in clinical practice, it is very difficult. It is distressing morally, and the colleagues are very much stressed in deciding whether to escalate the management and all. And as you know, COVID management is for free in all our COVID centers. So the patients and the family needs to continue all the management, but the resources we are having are very limited. So there is a dilemma of continuing all the management from other patients for those patients who are not surviving, and losing those patients who are surviving. These are the challenges. I will continue with the other questions.
Great. Thank you, Dr. Mambo. Really appreciate that. Again, I think I'll also come back to you with, I think, some of the next steps in terms of what can be done differently. Dr. Reddy, I know you have been, building the capacity of healthcare workers and also in the front line. So from your perspective, what are the real challenges that you're facing in this regard?
Thank you, Dr. Tigistu. So I'd like to start by saying every life is precious. And so that's what makes it so difficult for the healthcare providers to prioritize. So I had a chance to see different COVID centers, and the burden of this and the burden on the healthcare providers is so enormous. And to accommodate as many patients as possible, the healthcare providers are constantly innovating ways and extremely stressed. I felt through the different supervisory visits that I've had that the healthcare providers are stressed. And in addition to that, the burden of critical COVID is increasing drastically. And the difficulty in prioritizing patients for critical care in a setup already functioning with extreme limited resources is clearly evident now, and it's becoming more evident each time nowadays. It's extremely challenging to choose a patient who might or will, or maybe not, we don't know, get the best benefits of the critical care. It's morally demanding, ethically challenging for the healthcare providers, and sometimes it can even be, as Dr. Salam mentioned, it can even be a medical legal issue. So the healthcare providers might not feel protected to choose whichever patients might benefit. So it is also sometimes difficult to give a clear judgment of who literally will benefit. It needs knowledge, it needs guidance, it needs evidence-based paperwork. So unavailability of these clear written documents that guides or dictates the prioritization for critical care admission and resources is really, really a big challenge that I've witnessed it in these COVID centers. Sometimes 10 patients for one ICU bed. So choosing one patient on that line and prioritizing which will be, who will benefit most has become one of the greatest challenges nowadays. And adopting international recommendations is good, but it may not necessarily apply to us currently with our status, considering the resource allocation and the manpower limitations that we have. So that gives it an additional challenge. But I've seen some institutions coming up with their own criteria, or using the Ministry of Health's admission guidelines, the previous one that was there prior to COVID, and they come up with their own criteria, but that's not a formal one. So I've seen them use criteria like age, presence or absence of comorbidities, the number of comorbidities, the degree of oxygen requirement, and whether or not the patient has AKI. For example, if a patient comes with acute kidney injury in the presence of a chronic kidney disease, then that may not be an appropriate patient for an ICU admission. But then if a patient has an AKI and still COVID positive and requires critical COVID care, then the patient might be prioritized. So the presence of all these unavailable resources are considered. So they don't have a clear written document, but they are challenged to combine all these parameters to choose for a single bed or two. So that's very challenging. So like I said, every life is precious, but the healthcare provider's life is also precious, and we have to think about the morally, how degrading it can be to choose to choose one bed, one patient over another, because the patient has one comorbidity and we're not even sure the patient might make it after admission to ICU. So I highly suggest coming up with a concrete evidence-based outcome predictor or score that are specific to our setup, considering our resource limitation, and that are legally and morally protective to the healthcare providers. And I also share some of thoughts that Prof. Adam mentioned, like trying to protect the healthcare providers morally. So some kind of support on that line is very important. Thank you.
Great. Thank you, Dr. Redit. I think, all of you, Salam and Membo and Redit, you've raised some of, I think, the challenges that you're dealing with. Maybe a few minutes for Adam and Bhakti. I know you're practicing in a different context, but are there points that you want to weigh in and provide, share your experience? Bhakti?
So one of the things that I've often noticed or wondered is that when we think about ICU care and then care before the ICU, it seems to be like an all or nothing kind of framework, right? So you're either in the ICU or not in the ICU. And the challenge with patients, especially COVID-19 patients, is they go from 0 to 100 very quickly, but they can change very quickly too. And so it's really difficult to predict who needs the ICU. So one strategy that's been adopted that we have seen, especially in the United States, because there's never enough ICU beds, is this idea of having like an interim unit. So you identify patients in the emergency department, for example, who may have comorbidities, who just don't look good to you, who you want to be closely monitoring, who are too early for intubation right now. And they are put into a high dependency observation unit where there is more nurses, they can be closely monitored, they can be stabilized. So using your adjuncts to intubation, such as non-invasive positive pressure ventilation, high flow nasal cannula, and non-rebreathers, actively diagnosing and managing complications such as pneumonia. And the idea is to use this interim space to prevent progression to the ICU. And that strategy is somewhat useful because it helps maintain the ICU resource as much as possible. It decreases the flow of patients into the ICU, but it also then, like in a smart way, allows you to manage patients by protecting the limited ICU resources. So it's just, for those of you who are in leadership at health facilities and thinking about patient flow, this idea of how do you not only optimize the use of your ICU resources, but how do you decrease the number of patients going into the unit by providing early stabilization, resuscitation, and aggressive observation. It's just a strategy to consider.
Thank you, Bhakti, for the thoughts. Adam, any additional thoughts?
Yeah, sorry, I was just trying to turn my video on. I appreciate Dr. Tigistu, Dr. Salam, Dr. Reddit, Dr. Munbao for sharing their experiences. And I'm encouraged to hear that you've been experimenting with some different resource allocation strategies. And I think that having an organized way about going about this is very important, both for the patients and for the providers. I think the conversation with the ministry is going to be an ongoing conversation about at what point is a disaster declaration made, or are different levels of resource allocation going to be permitted. But I think on a hospital level, on an institution level, there are other things that you can do. And so I think having a committee of physicians, nurses, patient advocates, community representatives who sit down together and decide what should be the resource allocation principle, what should be the plan that you're using, is very important. And so one option would be to say that everybody gets assigned a score based on their illness severity, using one of those short-term mortality predicting scores that I showed you, and pick a score that works well for your environment, understanding that there's no single best score, but pick a consistent score. And if two patients have the same score, then maybe the next thing that you look at is who has the highest level of comorbidities that would predict poor long-term survival. And then if you have two patients that have the same short-term and long-term survivals, maybe the next consideration is age or other special considerations. But I think in an ideal situation, you can have that made into a poster that's on the wall, so that there's no question about what is the strategy that you're using and what are you following. And so even if it doesn't give you absolute protection as an individual provider, I think that saying that you're following an institutional policy and that you do the same calculation for every patient gives you much more protection both in explaining your thinking to the patient and to their family, and also if you were to have a threat to your license, to say, this is our institutional policy that was not just something that I made up on the spot, but that I was systematically and transparently following, I think is very important. You know, I don't know if that's something that the Ethiopian Society of Emergency and Critical Care Physicians would be interested in. Munbao mentioned the ICU prioritization score. And that's not something from the US government. That was something from the Society of Critical Care Medicine. So also a medical society similar to the Ethiopian Society, where a group of thought leaders and experts came up with a plan and then decided that we could all try to follow that plan consistently, because you guys as the frontline providers are going to have more insight and more of a sense of urgency than people who are not taking care of patients and making these decisions on a day-to-day basis will.
Great. Thank you very much, Adam. So we have 10 minutes, but I think I just want to go like to one quick round of I think what the next steps in terms of recommendations as well. And I think we've raised issues around supplies and staff and knowledge and skill and processes and protocols and governance, including legal and otherwise. So maybe Dr. Salam, specifically to the point that you raised, I know you are responding to some of the questions in the chat room, but from a legal perspective, what needs to be done? I think this is an opportunity for us to move along and look at the way forward. Maybe in a couple of minutes, if you can provide your recommendation.
I think from the legal perspective, I still think that the Ministry of Health should declare the state of emergency, and then let us have the admission committee and then activate this system, the ethical principles to prioritize patients at time like this.
Okay, thanks, Salam. So you're saying like we really need to take the oversight at a higher level, go back to, you know, almost like a state of emergency to kind of reinitiate or re-engage how decisions are made. And I think it is important to get the government to be involved differently.
Yes, because I'm sorry, because lately the issue is not just with ICU beds. Like, of course, we have 10 ICU beds, and sometimes you have up to 11 patients waiting for that ICU bed. But the problem is, we've been told to accept patients from the healthcare centers, and then the patients who are staying at their home, and even if they require ICU admission, just upon coming to the hospital, we're still forced to take those patients in, even though we don't have ICU bed. And the other issue is we have a very significant oxygen shortage in the past few days. And because of that, sometimes we're only left with like 10 cylinders because before the next the next oxygen arrives to the hospital. So if the government or the Ministry of Health doesn't make a decision fast, the problem we're facing will be much more than shortage of ICU beds. Like most patients are on CPAP or on high flow oxygens, like 50 liters, 20 liters, and things like that. So sometimes we don't have oxygen overnight. So we might even face a challenge, like even the patients with moderate COVID are sometimes in danger because the complete oxygen shortage might happen to the hospital.
Right. Thank you, Dr. Salam. Maybe quickly moving to Dr. Mambo. I know you mentioned different components from within the framework that needs to be addressed. I think the additional challenge we have is our solution needs to be iterative. We need to look at data on a regular basis and make changes. So there is nothing like a static prioritization. So given that kind of context we currently have, what are your specific suggestions that facilities, as well as, if you will, the association can put in place to really address, you know, as Bhakti put it, patients from 0 to 100 or back, so that we have intervention at every step of the way? Dr. Mambo?
Thank you, Tigistu. One point I agree with Dr. Salam. I think we have to work at a higher level, including emergency operating centers, to help them whom to admit to our ICU in our capacity, who will benefit the most from our limited resource. The other thing, as Dr. Salam said, expanding critical care beds is not easy in Ethiopia. Like they bought or they delivered ICU beds, sometimes mechanical ventilators, which were not probably user-friendly, or we have mechanical ventilator, but it is not only mechanical ventilator and beds which makes ICU bed. Like the human resource part, the oxygen problem we are facing now. So we have to accept it is so difficult to expand critical care beds as the demand. So we have to be like vigilant to the system and the number of cases we are facing, and day to day we have to have a prioritization model, and probably we have to set a panel of or experts, a group of experts to decide on ethical and legal parts on this issue. Probably we have to protect our healthcare professionals also, because some patients or families may be sometimes they may be violent, or they may be asking our professionals legally. So probably setting a kind of advisory team and deciding whom to admit, on whom to prioritize, and whether to escalate or our management. Like if lately almost in multi-organ failure stage, we are starting dialysis, which is almost futile treatment. So a group of or a team of experts should decide for such kind of ethical dilemmas. I think two things: helping or setting at a higher level, and organizing a team of experts to decide on such dilemma, maybe solutions.
Thank you, Dr. Mambo. I will actually definitely will take you on that final suggestion in terms of having a team that will connect, what needs to be done at the facility level and at the national level. Maybe something that we can discuss with the Ministry of Health as well. In terms of like protecting healthcare workers, I know Adam also mentioned about burnout and how beyond burnout, how challenging and threatening it is currently for healthcare workers. Bhakti, can you say a few words about what can be done?
Sure. So, let's acknowledge first that this is very real. Every single one of our panelists today have mentioned burnout, fatigue, resilience. And formal surveys have shown burnout in frontline healthcare workers, severe burnout, greater than 75% of individuals, with about 10% of individuals having severe burnout to the point that they are having suicidal thoughts on a regular basis. So this is real and it's not going away. I think there's three levels of strategies. The first is at the patient, in the real time within your clinical unit, access to drinking water and food, because we need to nourish our bodies, which has been very difficult with PPEs. When there is an adverse outcome, such as the death of a patient, a code that didn't go well, or an aggressive encounter with a family member due to patient care, and taking a moment to stop and debrief as a team, acknowledging like the challenge. And one thing I routinely do when I run a code, which is when I'm like resuscitating a patient, is I implement 30 seconds for my whole team to close their eyes and say a prayer, or just take a moment of silence, whatever their belief system. But that pause acknowledges the life that we have lost, and that it is not normal for you to do that in one room and then move on to the next patient. At the health system level, so as directors and health facility leads, again, there's a couple of strategies here. Multiple shifts that are continuous have a huge toll. So trying to limit the sequence of shifts to less than 3 days. Nights in particular are more challenging than day shifts. If you're doing night shifts, having 2 nights, 1 off, where possible. Recognizing that families also have the burden of their children getting ill, lack of schools. So having flexible shift work so that they can attend to their families and give them breakfast and dinner in the mornings and the evenings is good. And then recognizing that your colleagues may be burnt out. And if you identify that, take a shift off their hands. That's one thing I do at Hopkins. So if I identify that a colleague is doing too many shifts in a row, I'm more senior, so I have the ability to work an extra shift and take one from them. And then the last thing is, I think there is now a new renowned focus that medical training has to include resilience training. And part of resilience training is developing a mindset to survive the moral injury that we're all facing. And I have put some resources in the chat. And the last thing is hugs and kisses from your children. Try and get as many of them in as possible safely.
Thank you, Bhakti. Looks like your daughter is telling you it's time, so it's great. Thank you for sharing those thoughts. I know we're at the hour, but I really appreciate, I know this is going to be the beginning, and I look forward to have a follow-up conversation on what can be done, and actually like a pretty much solution focused and engaging, you know, all relevant stakeholders that can help us change the situation. We can't continue to discuss this. We're in a situation where this needs to be solved yesterday. So I think our next conversation is going to be focusing on solutions, including some of the things, Mambo, that you mentioned. But again, I would really like to thank you very much, the panelists, as well as the attendants, for showing up today to talk about something that is really difficult and broad. But if we come together and be very objective and scientific, I believe there will be a solution and we can save more lives and also protect ourselves. Again, thank you everyone for joining today's webinar, and we look forward to have a follow-up conversation with all of you.